Hello, everybody. Thank you very much for the kind invitation to participate in GlocoAlex 2022. Actually, the idea is very nice to talk about the guidelines of various types and the stages of glaucoma and best wishes for your conference. The angle closure disease is defined as contact between the periphery of the iris and the trabecular meshwork for at least two quadrants. And this contact could be a positional or synechial angle closure, and we will differentiate using the indentation gonioscopy. The angle closure disease is a severe form of glaucoma so that it blinds people equally like the primary open-angle glaucoma, though primary open-angle glaucoma is 3 times more prevalent than angle closure disease. According to the level of evidence, it could be high, moderate, low, or very low. And when we say that something which is high level of evidence, that means that further research is very unlikely to change our confidence in the estimate of effect, like the well-controlled clinical trials. It could be moderate, where further research is likely to have an important impact in our confidence in the estimate of the effect and may change this estimate, like the small controlled clinical trials and unrandomized studies. Or it could be very low level of evidence, which means that further research is very likely to have an important impact on our confidence in the estimate of the effect and is likely to change the estimate, like the observational studies, or it could be very low level of evidence where an estimate of effect is very uncertain. Regarding the recommendations for practice could be strong, that means that do it or don't do it, means that it's a judgment that most well-informed people would make. If it is weak, so that it's probably do it or probably don't do it, means that the majority of well-informed people would make, but a substantial minority would not. So that when it comes to the general condition, you will say like high evidence and strong recommendation, which means that it's a very strong information, please do it. As most of you would know that the angle closure disease is generally classified into 3 stages. It could be the primary angle closure suspect, where there is contact between the periphery of the iris and the trabecular meshwork, which is the iridotrabecular contact, for more than 180 degrees. At this stage, the pressure of the eye is normal and the optic disc is normal, so it is just called suspect. Now, when the pressure is high, beside the previous criteria, this is called primary angle closure or PAC. Then, when the elevated intraocular pressure affects the optic nerve, this is called primary angle closure glaucoma. So there is an evidence of glaucomatous optic neuropathy. Besides that, when it comes to the angle closure disease, also there is an acute angle closure crisis, and we have the chronic form, which is the primary angle closure glaucoma. Usually it reflects the chronic form of the disease. Let's go through the most important guidelines regarding the angle closure disease so far. I will start by the primary angle closure suspect. When you see in the clinic a patient with shallow anterior chamber and no other abnormalities, please know that the risk of developing glaucoma in those patients is extremely low, and it is estimated to be less than 1/1,000 per year in the Chinese. That was behind the recommendation that patients who are silent and having just shallow anterior chamber, we shouldn't proceed for PI on those patients. And this piece of information is high evidence and strong recommendation for practice. For some diagnostic issues, that gonioscopy is the most important for the diagnosis, and anterior segment OCT is helpful for the follow-up and supplementary test. And also it is not recommended at all to subject patients with angle closure disease to provocative tests. There is a subset of patient with shallow anterior chamber, that's a subset of PACS called PACS plus, and those patients we usually feel more worried about them, like a patient who is one-eyed and having shallow anterior chamber, like patient living in a remote area, like a patient who is going to have frequent dilatation of the pupil for fundus examination, persons using antidepressants and anticholinergics, and patients living in a remote area where the access to the medical care is not easy. And in those patients, you are justified to do a prophylactic laser PI if you feel that's you are going to help your patients. But generally speaking, with PACs, we don't do PI except on patients with plus disease. There might be a consideration for PI on those subset of patients. Regarding the management issues, uh, phacoemulsification and lens extraction is preferred over laser peripheral iridotomy for primary angle closure with pressure above 30 because that was the inclusion criteria in Eagle's study. And actually, patients who are having primary angle closure and pressure is less than 30, so far they are not well studied whether they are going to benefit from laser PI or phacoemulsification. In some of the patients, we like to add goniosynculitis, but actually it has been shown that it has no beneficial effect, and the recommendation here is weak and the evidence is moderate. So there is a still place for further work in this area so far. There is no need to stop anticoagulants for laser PI when the INR is less than 3. So again, you can find that the combination between the level of evidence and the recommendation for practice, like phacoemulsification, actually high evidence, strong recommendation. For synoculitis, it is moderate evidence and weak recommendation, so that we still do goniosynoculitis for some patients. And again, you can combine the level of evidence with the recommendations for practice. Regarding the location of the PI, there is no consistent evidence for the location of the PI affecting the dysphotopsia. So generally speaking, PI may be placed at either superior or temporal locations, and again moderate and weak, so still some research is needed in this area. Laser peripheral iridoplasty doesn't lower the intraocular pressure. Yes, it is performed on patients with plateau iris, but it doesn't reduce the intraocular pressure, and again you can find that it's high evidence and strong recommendation. But again, it's curative because it prevents further attacks of angle closure glaucoma. So again, for patients with PACS, that's a shallow anterior chamber, normal intraocular pressure, normal optic nerve head, you don't have to do anything except when the patient is in the plus category. You feel worried about this patient, you are justified to do laser peripheral iridotomy. But generally speaking, the strongest recommendation generally for the laser PI, if the patient sustained acute angle closure glaucoma in one eye and then dealing with the second eye, you need to do at least PI in those patients. Now, for a patient presenting with acute angle closure glaucoma, the medical treatment is the first line, and you give aqueous suppressants and systemic acetazolamide and topical steroids as well, and then topical pilocarpine. Then you are going to proceed for bilateral laser iridotomy. But again, the evidence is low and the recommendation is strong because there is a debate between the phacoemulsification, subsequent phaco, or laser PI. Definitely, if the patient is having coexisting cataract, you need to control the glaucoma and then proceed for a lens removal as soon as you can after quietening of the eye. If the patient's pressure refuses to go down during the acute attack, so it means that the attack is a persistent acute angle closure glaucoma. Actually, paracentesis has no proven role in the management in those patients and even might be risky. You can do a laser iridoplasty, but the cornea is sometimes very edematous and doesn't allow for iridoplasty. Laser cyclophotocoagulation could be considered. It's a good option, especially when it's applied to 180 degrees. This will break the acute attack until you can continue your proper management. Regarding the surgical options, patients presenting with primary angle closure glaucoma, nowadays phacoemulsification is the option of choice, and the evidence is high and the recommendation is strong. So according to Eagle's study, patients presenting with primary angle closure and pressure above 30 and those with primary angle closure glaucoma, we go straight ahead for phacoemulsification. We can combine with goniosynucleolysis, but still a lot of work needed in this area. Interestingly, the lens extraction in phaco is superior definitely to trabeculectomy and even superior to combined phaco-trabeculectomy, but there is still a consideration for the combined phacotrab in severe cases. But again, phacoemulsification, phacoemulsification, and phacoemulsification. There is no rule for the MIGS so far in angle closure glaucoma. There is no rule for the non-penetrating glaucoma surgery in the angle closure glaucoma. Interestingly, for the medications, prostaglandin monotherapy is effective in lowering the intraocular pressure in primary angle closure glaucoma. Again, the medical treatment is usually temporary until you go ahead for the surgical management. But again, the first line of treatment, if the patient is having primary angle closure glaucoma, so it's a quiet eye, it's not an acute attack, then you can proceed with prostaglandin therapy. If we think what's high evidence and strong recommendation, that the incidence of the angle closure glaucoma in a patient with shallow anterior chamber is very low. So we do not proceed for PI and we do not proceed for any provocative tests for the diagnosis or the monitoring. And the lens extraction is very, very helpful and is superior to laser PI for patients with PAC and with primary angle closure glaucoma. Laser peripheral iridoplasty doesn't lower the intraocular pressure. Laser PI is not advised in PACs with no other risk factors. Clear lens extraction is superior to laser PI in patients with primary angle closure glaucoma, and the prostaglandin monotherapy is effective in lowering the intraocular pressure in patients with primary angle closure glaucoma, definitely before you proceed for surgical management. So according to the stage of the disease, if it is PACs, then nothing to be done. If it is PAC, then phaco if the pressure is above 30. If it is primary angle closure glaucoma, then phacoemulsification. And these are my references, the Royal College of Ophthalmologists in 2021, the guidelines for angle closure glaucoma, and the European Glaucoma Society in 2022. Please accept my best wishes and thank you very, very, very much.